benefited. We have our Chief Coordinator, Dr. B.N.R. Subudhi sir, our President, Dr. Pranab Ranjan sir, was always guiding us, and our mentor of the program is none other than Dr. Ajit Babu Machi. Our Chairman, Scientific Committee, Dr. Shobhashachi Patnaik, is taking all pains to coordinate with the program. We had as our speaker, Professor Dr. M.D. Javed Ali from LPPI Hyderabad. His topic is evolution of the lacrimal system and lacrimal surgeries. We had the moderators who are very much experienced in their respective field. They include Dr. Madhushmita Behera, Dr. Gyan Vaskar, and we had panelists like Dr. Sharmishta Behera, Dr. Ruma Das, Dr. Chandana Chakravarti, and Dr. Rajesh Majumdar Chaudhary. We had our discussant from different postgraduate institute in the EIZOC states and beyond. Mostly they are PG students. With this, I welcome everybody and request our president to give the welcome address.
Thank you, Dr. Swaraj Bhattacharya, and good evening, everyone. And on behalf of EIZOC, I welcome you all to this resident teaching series webinar. I welcome today's learned speaker, Professor M.D. Javed Ali, who will enlighten us on lacrimal system evaluation and surgery. We have a team of distinguished panelists in Dr. Sharmishta Behera, Dr. Ruma Das, Dr. Chandana Chakravarti, and Dr. Rajesh Chaudhary. And to take us through the webinar, we have two dynamic moderators, Dr. Madhumita Behera and Dr. Gyan Bhaskar, along with a bunch of 10 discussants from different medical colleges of the East. Welcome you all. And before I hand over the proceedings, my sincere thanks to the mentor of the program, Dr. Ajit Babu Maji, the chief coordinator who has been burning midnight oil, Dr. B.N.R. Subudhi sir, secretary, the dynamic secretary, Dr. Swaraj Bhattacharya, and the chairman scientific committee, Dr. Shobhashachi Patnaik. And finally, I welcome the esteemed audience. Over to you, Dr. Swaraj and Dr. B.N.R. Subudhi sir.
Okay, so let me share the screen, my screen. Respected President EIZOC, Dr. Pranab Ranjan ji, Secretary Dr. Suraj Bhattacharya, my friend, my mentor Dr. Ajit Babu, and my friend Dr. Shobhashachi Patnaik, and I welcome you all to the today's EIZOC ORTS 22 webinar. As you know, this is the mostly postgraduates for the postgraduate students of not only EIZOC states all over the country. And today's topic is a very, very interesting topic is evaluation of lacrimal system and lacrimal surgeries, very common surgery. I mean, everybody is doing this surgery. So that's why today more than 10 postgraduate students are participating in this program. And of course, today's speaker is Professor Javed Ali. And my colleague, Dr. Madhushmita Behera, will introduce him today. And this is our EIZOC team, always supporting, guiding me. President EIZOC, Secretary EIZOC, and Chairman Scientific Committee for this program. And we have already completed 22 episodes, and we are moving strong with our mentor, Dr. Ajit Babu Maji, who is constantly guiding me for the speakers and sometimes the panelists and moderators also. Today's moderator already Dr. Pranab has already said, Dr. Madhushmita Behera and Dr. Gyan Bhaskar. Everybody knows these two people very well in not only the EIZOC. Can you see me?
Yeah, we can see you, sir.
Okay.
We can hear you also.
Today's the panelists already discussed by our EIZOC team. And of course, today's discussions, as I told you, there were 10 most enthusiastic postgraduate students who have participated in this today. And Dr. Smruti Mishra from Limsar Burla, Dr. Shravani Sarkar from Silchar Medical College and Hospital, Dr. Lakshmi Saju, again from Silchar Medical College and Hospital, Dr. Shraddha Sataprava, she's from JPM Rotary Hospital, Cuttack, Dr. Sonali from RIO, SC Medical College, Cuttack, and Dr. Subhasri Prushti from MKC Medical College, and Dr. Rishabh Seth from Ruby Eye Hospital, Barampur, Dr. Soumya Panda, Agrawal Sai Hospital, Cuttack, Dr. Utkarsh Agrawal, AIMS, Bhubaneswar, Dr. Subhasri Sahu, MKS Medical College, Barampur. So today's discussion very, very interesting because the topic is also interesting and we got a lot of postgraduate students. And before I close down, I welcome you all once again. And just small announcement. And next week we are starting our program, that is EIZOC Ophthalmic Research and Publication Initiative Program, which has paused for last more than 1 year. And next Tuesday, 9th April, 8 p.m., we will have this program restarts, rather say, and the topic will be a very interesting topic: how to initiate and generate interest in the research and publications. And the speaker is none other than Dr. Bharat Gurnanan. So, these few words, I welcome you all to today's webinar, EIZOC ORTS 22 program. It's over to you, Dr. Madhusmita Bera. Thank you.
Respected sir and madam, good evening everyone. No introduction is required for Dr. Javed Ali. We all are fortunate to have Dr. Javed for this session, mainly for residents. Dr. Javed is an internationally recognized oculoplastic surgeon. He currently heads the Department of Dacrylology, LB Prasad, Hyderabad. Dr. Javed is also the Distinguished Alumni Chair of Ophthalmology at LB Prasad, Hyderabad. He is the receiver of Lester T. Jones Award. He is also the receiver of Shanti Swarup Bhatnagar Laureate Award. He is the editor-in-chief in seminars in ophthalmology. He is also the associate editor of Survey of Ophthalmology, Ocular Surface and Ophthalmic Research. In the editorial board, he has 24 journals. He has 627 publications, 41 awards, and 403 invited lectures. Today, Dr. Javed will talk about evaluation of lacrimal system and lacrimal surgeries. Dr. Javed, over to you, Dr. Javed.
Thank you, Dr. Madhusmita. I'll just share my slide. Yeah. So I thank EIZOC, Dr. Subudhi, Dr. Pranav Ranjan, and Dr. Ajit Babu to have given me this opportunity to be presenting after a long time for postgraduates. And it's always a challenging task to teach postgraduates, not easy. So I bring to you greetings from the LV Prasad Eye Institute. So today we will talk about evaluation of the lacrimal drainage system. I'll see if I can just move the slides. Yeah. So these are my financial disclosures. And a lot of these images that you see, almost all I would say, is from 2 volumes of this atlas of lacrimal drainage disorders. So the overview would be, we'll just delve a little bit on to the lacrimal drainage anatomy. A lacrimal system has progressed by leaps and bounds in the last 10 years. It's a lot of concepts that we were taught when I was a postgraduate is no more true. I'll just touch upon few of them from the evaluation perspectives. And obviously I will not be able to cover a lot of them. We'll learn how to evaluate lacrimal drainage system right from the face to the punctum and canalicular region. We'll discuss few concepts in lacrimal irrigation. I don't call syringing. Syringing is not a good term to say that. Syringing means any place where you put a syringe. It could be an injection, can also be a syringing. So I usually use the term lacrimal irrigation. And then we'll discuss how do we systemically document any lacrimal drainage evaluation. And obviously, if time permits, I'll briefly take you through endoscopic evaluation and examination. Lacrimal drainage system, as you are aware, is both an anatomical and functional marvel. I'm yet to come across any drainage system, both natural or man-made, which can match the greatness and the amazing characteristics that are present in the lacrimal drainage system, including the valvular structures all across from the punctum to the nasolacrimal duct opening. And this system is something which has fascinated me from my fellowship days. This is a picture of mine during my fellowship days a decade ago. And these are some of my cadaveric dissections that I did in Germany. Just to briefly let you know the location for the postgraduates where exactly the lacrimal drainage is. As you can see, it's somewhere broadly between the eyes and the nasal cavity. And this is how a completely dissected lacrimal drainage system looks from the punctum to the canalicus to the lacrimal sac. And down here that you see is the opening of the nasolacrimal duct, which is not how it's drawn in the textbooks, right? Textbooks draw it as a very narrow pipe that comes and opens up, but it has such broad fang-like opening into the nasolacrimal ducts. And if you cut open the lateral wall of the nose, that's how the lacrimal drainage system is intricately associated with the nasal cavity. Now, if you see here, this is the lacrimal sac, and there you see the nasolacrimal duct coming, and this is a fang-shaped opening that you see into the inferior meatus. I have removed the inferior turbinate here, just so that it's very easy for you to assess how proudly the lacrimal drainage system stands on the lateral wall of the nose. And this is just one of those cadaveric dissections where, just to show you, the lateral wall of the nose has superior turbinate, this is the middle turbinate, and this is the inferior turbinate. I've removed both the turbinates, and there you see if I'm probing from somewhere, it's coming right through the inferior meatus. So what does it mean? It means that a lot of it, approximately 60% to 70% of it, is housed in the lateral wall of the nasal cavity. So it is not possible for someone to do a fantastic work into this system unless their nasal anatomy, nasal physiology, nasal clinical examination, nasal operative routes, these are all there in their armamentarium. If you don't have those skills, they will not be able to do justice. And that's one of the reasons why this system has been known since antiquities. The first description of lacrimal drainage intervention was in the Code of Hammurabi, somewhere in 2250 BC, somewhere 4,000 years back. There's a description of how do we deal with lacrimal abscess. So it's not that it is not known since antiquity times. It's just that people have isolated themselves, and half of the system we are not aware as eye doctors, and same thing would be with the ENT guys. So it's very important to get trained in both the areas to be able to do a very good job with the system. Just to give you an example, this is one of the dissections that I had performed for the lacrimal, proximal lacrimal drainage, which composed of the punctum, as you see here, and this is the canaliculi. Now, if you look at the upper one here, you see a vertical canalicus, right? You see a vertical canalicus, and then you see a nice horizontal canalicus. But it is never like how it is drawn in the textbooks, one nice vertical thing and one horizontal. It's never like that. It has something called as an accordion phenomena. So it is something like this. It is never like a straight tube. Okay. And if you look at the same patient's lower proximal system, you don't see a vertical canalicus like we normally see. So here from the punctum, it directly angulates and gets into the horizontal canalicus. So the concept that everybody has a vertical canalicus like 2 millimeters and then 8 millimeters, that doesn't happen. Okay. Now, we did some very, very detailed fundamental molecular biology studies on the muscles around the lacrimal system. And last year, we proposed the mechanism of how actually tears flow from the lacrimal drainage into the nasal cavity. Like when somebody is closing their eyes, approximately 2/3 of the canaliculi has the Horner's muscle. Horner's muscle does not take up the entire canaliculi. That's important to remember, right? Horner's duodenum, I would call it. It's we have renamed that muscle, and that muscle name has now been changed to Horner duodenum muscle because duodenum's contributions were far more significant than Horner's contribution. Anyway, so for the Horner's duodenum muscle, when you look at it, it is only up to the medial 2/3 of the canaliculi. The lateral 1/3 of the canaliculi does not have that innervation. So what happens is whenever we close our eyes, this segment is compressed, and a part of the Horner duodenum muscle goes and attaches to the posterior aspect of the lacrimal sac. So what happens is something contracts, the lacrimal sac expands, and this area gets contracted and the remaining area gets expanded. So two things happen. One, the physical mechanisms, by compression itself, the tears are propelled into the distal segment, and by the expansion of the lacrimal sac, a negative pressure is created in the lacrimal system, which sucks the fluid. So those two things act simultaneously, and then the fluid gets into this system, tear fluid. And then subsequently, when we open our eyes, right, the muscle stops acting, so the medial two-third expands. And for the reverse mechanism, the whole of the distal segment contracts, and this propels the tears right into the inferior meatus. This is a little oversimplification, but just for the postgraduates. So when we want to evaluate something clinically, this is no brainer. We have been reading it since our medicine days. A meticulous history. Meticulous history means meticulous medical history, meticulous ocular history, meticulous surgical history. So all these things are going to happen, right? For example, meticulous medical history can be, is somebody a coexistent glaucoma patient who's using anti-glaucoma medications for a long time? Has somebody been on chemotherapy in the past? Just to give you examples of how all those things can influence the lacrimal drainage system. Has somebody operated somebody's eyes, or has there been a periocular surgery that could have influenced the lacrimal drainage system? So that's some meticulous history. And then you start looking at the face, right? We don't jump onto the lacrimal system. So I'm just giving examples. I don't have written matter in my presentations. All are images just for you to understand and drive broadly the points that you need to evaluate. Like, for example, if I look at this gentleman's face, what is it that strikes me? What strikes me is this particular stent, which is acting like a foreign body here. If this gentleman complains of watering, I obviously know what is going wrong, isn't it? So evaluating the face gives a lot of clues. If somebody has something called as a mid-face ptosis, where the middle part of the face in elderly people go down a little bit, and that can change the position of the punctum in the lacus lacrimalis. Another example, just looking at the face, you know what is probably going wrong in this baby as far as the lacrimal drainage system is concerned. This is anyway a congenital dacryocele. Previously, it used to be called amniotocele, which is not a true correction, not a true term to describe that one. Congenital dacryocele. Then go on to the periocular area and assess the periocular area after you assess the face, right? If you look at this gentleman onto your left, there's obviously an ectropion, right? An ectropion. So if somebody has an ectropion, obviously the punctum is not in the lacus lacrimalis. That's one reason for epiphora. The second reason for epiphora in these patients are that people who have ectropion for some time, the punctum has something like a diffuse atrophy and it gets stenosed. 10% of ectropions have associated punctal stenosis. So these are, it gives you a certain clue of what you're possibly dealing with. And again, periocular, like in this kid, if you look what's happening, there's a nice epiblephron in this kid. And what that epiblephron is causing pseudotrichiasis. And that is causing epiphora, as you can see. There's a lot of TF meniscus height is quite high, more so in the lacus lacrimalis here. Gives you an idea of what we are dealing with. You should also look at the eyelids for laxity of the eyelids. We can do that by something called as lateral distraction test, or you can do something called snapback test, where you pull the snap. Okay, so if you have grandparents at home, do that, right? Pull your eyelid and leave it, and then you see within no time it snaps back, and you will hear, if you are in a quiet room, you'll be able to hear that snap of the eyelid going back and into its position. But if you do that for your grandfather, you will see that it takes some time, or he might have to blink to get that eyelid back in position. So those are signs that eyelid is lax. And if there's eyelid laxity, obviously it's going to influence the muscular activity of the hornus, which is in the medial part of the eyelid. Then once you get to know about the face and you have looked at the periocular area, it's a good idea to just observe for the tear meniscus, how the tear meniscus height is there. And you can, I'm sure you guys know how to measure tear meniscus heights, but grossly you know whether tear meniscus is normal or abnormal at your stage. And then you look at the Schirmers just to rule out either dry eyes or hypersecretive components. It just gives you some gross idea at this point of time. And then you start going towards the lacrimal system now, right? So you looked at the face, you looked at the periocular areas, you have looked at your meniscus height, Schirmer's, and now you go towards. And before you get towards the punctum, look for something around the punctum. Is there something like in this particular case, you see a nice caruncular hypertrophy, which is causing a mechanical obstruction of the punctum. Or in this particular patient of thyroid eye disease who had come specifically for with complaints of watering, what do you see? You see that there is a little bit of conjunctival and conjunctival chemosis, more so medially. So what is happening to this conjunctival It's coming on to the punctum, completely mechanically obstructing the punctum. So you, by having a look like this, you can grossly figure out what's going wrong. And once you finish all these things, now you come to the punctum. And when you look at the punctum, the first question is it present or is it absent? Okay, so if it is present, you see like this onto your right, and onto your left, you don't see any punctum, right? So punctal agenesis. So is the punctum present or absent? That's the first question to answer. And if the punctum is present, then look whether the punctum is in its position or not. Like in this individual, this is the condition which is called as Centurion syndrome, where the punctum is away from the lacus lacrimalis. Now, you see, it's a very high magnification thing, but you know what is happening. The punctum, see, as the eyelid is coming, it is rising above. Why? Because the anterior canthal tendon is inserted a little more anteriorly in these patients. So what happens? The eyelid punctum area is lifted up. It is not exactly in contact with the lacus lacrimalis here. So this is obviously the cause for his epiphora. Or in this particular case of an elderly gentleman where without touching, because you see that the lids here are okay, but what is happening here? There is a medial ectropion, punctal ectropion. So one simple test, if you are able to see punctum without aversion, it means that there is a punctal ectropion, as simple as that. So this is a case of a punctal ectropion without a gross ectropion of the eyelid. So that's something that we need to catch up. Right. So whether punctum is present or absent, then punctum positions, then comes punctum proper. Is it normal or is it stenosed? Right? If you have seen enough number of normals, you know that this particular patient is stenosed. I'll show you how the normal looks like. Right? So this is how the normal looks like, the black arrow. And see again how a stenose looks like. So what is happening? Other than the narrowing, what do you see just around the punctum? You see a little whitish discoloration all around it. It just means that there is some kind of fibrotic events that are happening in that area, right here. So you look whether punctum size is normal or not normal. And then you look whether punctum, if it is present, is it normal or does it have a membrane over it? Like in this particular patient, this is a condition which is called as incomplete punctal canalization or IPC, where the punctum has this nice membrane over it. So these are obvious causes of epiphora. Then you go a little beyond punctum. Still, we are grossly, okay, we're not going into lacrimal examination proper. Still evaluating and observing, right? So what do you see here? You see that the canalicular is a punctum which is a little hypertrophied, and then you have this large canalicular area with inflammation. This is a very typical case of a canaliculitis that is causing epiphora. And canaliculitis can be missed for years together, being diagnosed as chronic conjunctivitis. So that's something that you should be aware of it. The other thing is that if you have a little suspicion in not so innocuous or not so glaring cases of canaliculitis, as you see, what I'm doing, I'm just compressing that area of canaliculus, and there you see a nice discharge coming. This also is a sign of an early or a very chronic canaliculitis. And then once you have taken and ruled all these things out, then you look at something called as fluorescent dye disappearance test. See, you have not even touched the patient so far, right? So fluorescent dye disappearance test, you place a drop of fluorescein into the conjunctival cul-de-sac and then look at how it disappears. Like in this particular patient, at the end of 3 minutes. 3 minutes is usually considered as enough. Some people do it for 5 minutes also, but 3 minutes, it should disappear most of it by 3 minutes. Like if you see here at 3 minutes, what has happened to this individual? It's all gone. There's a little, very little bit in the conjunctival medial fornix here, which is more of an error. But you see, So you then grade the fluorescent dye disappearance test from grade 0 to grade 5. Grade 0 is no retention, grade 5 is complete retention, and mild, moderate, severe comes in between. This is one example where you see on this eye here, very little, almost everything has disappeared. But look at this, it's almost the entire thing is still there. So this is almost grade 4 to grade 5 of retention. Rarely you can also see the fluorescence coming from the nasal cavity, more so in pediatric patients. That also is an indirect indication of the patency of the lacrimal drainage system. So you do fluorescent dye disappearance test, and then in fluorescent dye disappearance test, so don't go after Jones and Shermers. Those are all outdated investigations. Nobody does Jones investigation because it's not very specific. Now, so the next thing, if you see that the fluorescent dye disappearance test is raised or something, then you obviously look around, as I said, in the periocular area. And in this particular case, what I'm finding is that there is a little bit of lacrimal sac swelling. Even if there's no lacrimal sac swelling, you can compress this area over the lacrimal sac, as is shown in one of these very beautiful schematic diagrams drawn by my fellow Himika. So you compress the lacrimal sac. So if there is some regurgitation that's happening into the conjunctival cul-de-sac, it broadly means that people have either a very severe stenosis or obstruction of the nasolacrimal duct. There are exceptions. I don't want to get into that one at this point of time. So this test is called as ROPLAS, or if you know the mnemonic, regurgitation over pressure on pressure over lacrimal sac area. So if there's regurgitation on pressure over lacrimal sac area, or ROPLAS, it's called ROPLAS positivity, which is an indication that there is a possible distal stenosis or obstruction. Now, this is a specific diagram that I have put up because we have been conventionally taught when we want to irrigate or do so-called syringing. I'll use term irrigation again, I'm saying. So whenever you want to irrigate the lacrimal system, this is what we have been taught, isn't it? We just go vertically, dilate it, and then go horizontally. And when you're going horizontally, stretch it, right? That's what has been the conventional teaching. That's not true. That's not how it's supposed to be done, because this is very oversimplification of the belief that the lacrimal drainage system is one vertical and one horizontal pipe. It's not so. As I said, the canaliculi have something called as accordion phenomena, where they are not ever in the straight line. It goes on like this, right? So if you want to get and negate all those angulations to be able to get in, the stretch should be the first step. Okay, I'll just give you an example. Like if you see in this particular patient, what I'm doing, I've not even gone into the vertical canalicus. I'm trying to go into the vertical canalicus, but you see the lid is lifted up and stretched out. And then you get into the horizontal canalicus. And remember, taking any instrument into horizontal canalicus, it should always lie flat and parallel to the lid margin. Wherever if the lid margin is like this, it should lie like this. If the lid margin is like this, it should lie parallel to the lid margin. That's one way to negate all angulations on a stretched eyelid and to avoid injuries. A lot of injuries that I get to see from patients who are referred is iatrogenic injuries to the canaliculi, because we have not learned to do good irrigation, lacrimal irrigation or syringing. That's a very, very important technique. After 12, 15 years, I'm still not very confident about doing a lacrimal irrigation because it's that complex anatomy inside. So we need to be little mindful and careful about it. And the tissues that we don't respect, the tissues don't respect us back. Remember that. Okay. Another concept that we have been taught wrong is the use of these kind of cannulas, and quite a bit of cannulas that you see in a lot of setups. A lot of things have changed, I would say, in the last 10 years. But still, interior setups have these kind of cannulas which are angulated, right? It's not a good idea to use angulated probes, angulated cannulas. I'll tell you the reason why. These are the cannulas that's supposed to be used. Straight cannulas, you get it at 23 gauge, you get it for 25 gauge, doesn't matter. You can get for all kinds of it. Don't use angulated ones, right? Why? Because if you look at this, these are just to give you examples of how things are, right? Look at that angulation that's happening. So That means when I'm going through the canaliculi, the diameter of the canaliculi is what? At the most 0.5. Some places it's even 0.3. So 0.5 millimeters, some tube is for 0.5 millimeters. And if you use something whose vertical dimensions are like in the left picture, you see almost 15 millimeters, in the right, you see almost 7 millimeters. So what is happening? You're taking of something vertical through a 0.5 millimeter diameter. So if you take large ones, then you are likely to scrape the canalicular walls without realizing that you have traumatized it. And these are not forgiving tissues. Canaliculi don't forgive if they are traumatized, right? And we don't, right? We don't, like if it's oral cavity or nasal cavity, we don't scratch those surfaces, right? Because we know that they can form synechys. Exactly similar concepts. So avoid using. It will take, anything in textbooks takes 10 years to get in and 30 years to get out. So it takes some time, but this is, a lot of people, postgraduates here, should understand that this is how things are to be done now. So this is again a schematic diagram just to show you that the stretch on the left is right from the beginning. See that stretch? The still vertical. It's all from the beginning. Right? That's one thing. The other thing that we should do is that use always 1 cc irrigation with a 0.5 cc fluid in that one, right? Because the bigger needle you use, the more pressure it causes onto the ampulla of the vertical canaliculus, and that causes trauma to the ampulla of the vertical canaliculus. So use 1 cc and use only 0.5 to irrigate. Again, the concept just to show you how I'm using straight cannula, getting in, and then when you see it's already stretched out, and then if I have to get into the horizontal canaliculus, this cannula will lie flat and in contact with the lid margin, right? It becomes very easy. Otherwise, a lot of soft stops that we get are actually erroneous soft stops. The concept of hard stop, a lot of postgraduates might have this question of the hard stop. Simple, and I'm just trying to, this is a little bit of oversimplification, but I'm just trying to show you that. So just putting up a probe there, if you have straight cannula that you're using, you don't need to use a separate probe for probing because you use the same thing to probe it up, right? So if you look at this particular patient, you see how this is the bone, right? This is the bony lacrimal fossa. And you see how the probe comes and touches the bony lacrimal fossa, and you get a hard stop. So in the pursuit of hard stop, don't press it hard to see. Why? Because it will traumatize this part of the lacrimal sac, and often you would see bleeding post-syringing or post-lacrimal irrigation. This is what happens, right? So you should not do that. And if there is a canalicular obstruction, then you would obviously get soft stop, as has been demonstrated in pictures B and C. Now, once you evaluate all those things and you document the findings, right, there's a way to document findings in lacrimal system. These are just to give you examples of how these are. Like partial obstructions, you draw like this. Total obstruction, you draw like this. If there is an enlarged punctum or following a punctoplasty, this is what it means. If somebody draws a round near canthus, it means there's a mucocele. Again, normal punctum, stenosed punctum, fistulas. There are a lot of ways in which it is documented. I'll just give you 2 or 3 examples. Right. This is how it's very easy to draw. This is how you draw it. What does this mean? This means that I have irrigated this patient from the lower canaliculi and it is patent. Irrigating from the upper canaliculi and it is patent. I'm irrigating from the lower canaliculus. There is a partial regurgitation from the upper canaliculus and there's a partial regurgitation, partial passage into the nasal cavity. That means there's a partial obstruction here. I'm irrigating from the lower canaliculus and I'm getting complete regurgitation back from the upper canaliculus, right? I'm irrigating from the lower canaliculus and there's an immediate regurg from the opposite canaliculus. That means the obstruction is somewhere here, right? More immediate and more coming more proximal to it, the more will be the fluid from that same punctum. For example, irrigation from the lower punctum, immediate regurgitation from the same punctum. That's how you denote it, which means that there is a canalicular obstruction. And based on the level, you can draw where exactly that obstruction is, proximal, mid, or distal. Here, what does it mean? I'm irrigating from the lower canaliculus, and there is partial fluid that the patient felt in the nose and partially was coming out from the fistula here, right? This patient underwent a punctoplasty previously, that's why it's denoted. And if I'm irrigating from the lower, it is patent from the nasolacrimal duct. So there are ways of documenting the lacrimal system examination. And obviously, as I say, if we don't learn endoscopy, we will never be able to do justice to the lacrimal patient. It's a very, very important skill because 70% of that system is within the nasal cavity, right? So we need to learn that, and it's not a big deal. It's far more easier than learning anything in ophthalmology. That's my experience. So it's very simple. So this is just to give you example. This I won't go into the examination of the nasal cavity proper because it's not needed at this point for this audience. But just to realize that, see the probe coming in, so you can probe the patients, you can evaluate from where the probe is coming. Is it coming from the right place or not? What is going wrong in the nasal cavity or the lower part of the nasal lacrimal duct, which can be addressed without doing DCRs, right? And this is an examination of the nasal cavity of the inferior meatus, where I am actually looking at the opening of the nasal lacrimal duct and how, to what level the fluid is flowing into the nasal cavity. And this is post DCR, where I'm trying to see how the irrigation is happening from the ostium that has been created. So just to summarize what we talked about today, always take a directed history. First step. And once you take a directed history, listen to the patient. The patient is going to tell you the diagnosis if you listen enough and carefully. And once you look at the history, then exclude causes of reflex tearing, because with the dry eye disease epidemic, so don't be surprised that if somebody actually turns out to be a dry eye who was having reflex epiphora, exclude those causes. Make sure that the punctum are normal. I have discussed how we look at the punctum presence, the positions, the size, right? And then assess the lid laxity to look at the functional components of the tear mechanisms. And if everything is okay, then palpate the lacrimal sac. And if you palpate the lacrimal sac and you don't find anything, if there's regurgitation, then you know the story ends there. But if after palpating the lacrimal sac, you don't get any clues, then irrigate the lacrimal system. And if irrigation is also patent, then perform fluorescent dye disappearance test to know the functional mechanisms that are happening for the lacrimal drainage system. And if everything is normal, look at the patient's nasal cavity. The cause lies there. So I think I just try to simplify as much as I can, and I can take up amount of discussions because I like keeping things short. As I was telling Dr. Ajit Babu the other day, human mind cannot take information beyond 30 minutes. So it's always better to limit to less than 30 minutes, and then we can have a wide range of discussions on anything that you want. Thank you very much.
So thanks, Dr. Javed. This is Dr. Patnaik, the Chairman Scientific Committee of the EIZOC. So it was so fascinating, your description of lacrimal system. So perhaps for the first time, I saw a person who have understood the lacrimal drainage system so well and explained it so well. I think there will be no doubts in the mind of the postgraduates.
Don't do anything in my life other than lacrimal. So somehow
we should invite questions.
Yeah.
Thank you so much, Dr.
Any questions
Javed. Thank you so much.
I want to ask that, sir.
Yeah, Dr. Moses. Yeah.
Dr. Javed, how often do you find rhinosporidiosis? And suppose you suspect rhinosporidiosis, should we still go for lacrimal passage irrigation?
Well, if you strongly suspect rhinosporidiosis, then it doesn't really make much sense to irrigate because it's always going to show erroneous readings, right? If there's a lot of granulation tissue within the lacrimal sac, it obviously is going to give you an impression that there is an obstruction when actually there's no obstruction in the distal segments. So that's one thing. If you're strongly suspecting it, then I would go ahead and do something about that, either medically or surgically.
One more question, sir. How significant or important is DCG in the evaluation of lacrimal?
Well, plain dacrocystography, I don't think it has any role anymore. And for that matter, even dacroscintigraphy. These are unnecessary investigations which have been just blown out of proportions in the 60s and 70s. And unfortunately, they continued like that. The role of CT DCG and MR DCG is there for lacrimal sac tumors or post-traumatic obstruction. So these are the two conditions where I use CT or MR DCG based on what I'm suspecting.
Thank you, Dr. Javed, for your nice talk. And one question is, oftenly we face a patient with the post-traumatic multiple fracture in the lacrimal sac area and orbital floor, sometimes herniation of the orbit fats and mucosal. What should be the key point to for the evaluation, and when should we go for the surgical procedure of such type of cases?
So when I looked at my data of doing interventions early on as a part of a multidisciplinary teams in major hospitals versus delayed kind of a thing, there's no difference in the outcomes as far as the time duration is concerned, right? Unless it's a canalicular injury. Here I'm talking about nasolacrimal duct injuries, because most of the fractures, especially orbitozygomatic fractures, which are a little common for around the orbits, they usually have a component of nasolacrimal duct obstructions. Unless somebody has a laceration and all those things, you need to repair early. But if for isolated nasolacrimal duct obstruction, which are more common, the important thing is to look at the positional with reference to the lacrimal sac. How is it positioned? And often there is a malposition of the lacrimal sac because of the distortions. Now, how the fractures have happened and all those things, and how the lacrimal sac was displaced. So there have been times when the lacrimal sac was displaced somewhere in the mid-orbit. Okay, and there have been times when the lacrimal sac was somewhere near the eyebrow. I'm just giving you the extremes of the spectrum in which the lacrimal system can get displaced, right? So that's where what Dr. Madhusmita was asking about. So for me, an important aspect is doing CT-DCG for positional relationship. I know there's an obstruction. That's no brainer that I will get to a simple clinical examination that it's an obstruction. But the positional relationship is how I decide based on a three-dimensional CT-DCG. And based on that, an approach is then chosen of how do I approach that particular system. And I wouldn't debate between external and endoscopic approaches. Depends. If there's a large fracture of around the orbit, I would then go with an external approach, because in one go that can also be repaired and lacrimal system can also be taken care of. And in most patients who, following facial fractures, they usually go to a multidisciplinary place from the road traffic place or wherever they meet with an accident. So most of these patients come back following maxillofacial repair. So then you have all the liberty and time to assess where it is and then take a call based on your comfort of choosing approaches based on the location of the lacrimal sac.
And one more question: do you do FDDT test in all your patients, be it adult or in case of children?
No. FDDT for me is very useful for pediatric patients. Adults, I don't unless I am suspecting a functional component to it. And so if there is an additional functional component to it, then that will help me prognosticate also. Suppose if somebody comes with a unilateral pando, okay, and then obviously fluorescent dye disappearance on that side doesn't make sense. But if the other side is patent, I do a fluorescent dye disappearance test, and if I find grade 2 retention, then I can counsel him that, look, boss, even if I do a DCR surgery, there's still going to be a 20-30% residual epiphora that you would have because of the functional component. So it helps in prognosticating.
And for lacrimal sac syringing, do you always do it through upper punctum?
Lacrimal irrigation, I am very fond of doing it from the upper punctum for a simple reason of the angulation with which the upper canaliculi enters into the lacrimal sac. It enters at an angle of 135 degrees into the canalicular sac. So what happens is, unlike the lower canaliculus, which comes 90 degrees to the lacrimal sac, and if you want to do a irrigation within the lacrimal sac, and to be sure that you are irrigating within the lacrimal sac, because what happens is that if you irrigate it within the canaliculus, then you might have erroneous readings. And you give me any normal patients and you want me to mimic anything, any obstruction I can mimic in that same patient who's normal. It just means that techniques plays an important role. And one aspect of the technique is that the irrigation should ideally be in the sac and should ideally be facing towards the nasolacrimal duct. That gives you the best kind of assessment. So that happens usually from the upper canalicus, because once you come from the upper canalicus, you are coming towards the nasolacrimal duct right like this. So one, you're confirmed about the sac. Second, you're confirmed about the angulation towards the nasolacrimal duct. So that gives a very good, reduces the chances for errors.
So, Dr. Javed, I think there are a lot of postgraduate students where the postgraduate students usually they do the irrigation in the OPDs, in the medical college OPDs. Let us ask them what they find the difficulties in doing this irrigation.
Yeah. If they're
So
around.
any postgraduate students, please do come forward and ask.
You can ask me anything, I'll still love you.
Dr. Subhasri, why don't you ask?
Sir, good evening, sir.
My name is Javed. My name is not sir, to the best of my knowledge. You can call me Javed.
Sir, thank you. Sir, actually, I had a question, sir. Am I audible?
Yes, you're audible.
Okay. Sir, how do we know if the epiphora is due to lacrimal passage obstruction or due to lacrimal pump failure without Jones test? Because in like you said, sir, it takes 10 years for something to enter the textbooks and then 30 years to get out. So
I'm really
actually,
got that line.
sir, because in the textbooks it's still written that in Jones test we can differentiate whether it's due to passage obstruction or due to pump failure. So, sir, how do we know without Jones test?
Very simple. Say, for example, if somebody has an obstruction, right? Any level of obstruction you can know by irrigation, right?
Yes. Yes.
That's done. Okay, so we have taken care of obstruction. So suppose if somebody has irrigation is patent and still somebody is having epiphora, that's the time when you will be looking at functional, right?
Yes.
Simple fluorescent dye disappearance test. Just put one drop and just wait and see what happens in 3 minutes. That gives you an idea how much pump is working. It's as simple as that. So why do we need to complicate things when we can know it by a simple drop, right? So it's important to simplify things.
Thank you, sir.
Anyone
Dr. Praveen, what should be the management protocol regarding the functional epiphora?
Well, functional epiphora, it's a very, very long topic. But functional epiphora at present, what I do for functional epiphora is the first step is for me is to do a simple balloon dilatation of the nasolacrimal ducts. Why? Because what happens is that for practical purposes, the nasolacrimal ducts and the canaliculi are spherical cavities, right? So spheres in broad sense. So if you look at the Laplace law, if you increase the diameter by twice, then the resistance to flow will reduce by 4 times, right? The Laplace law, simple. 1 by Rs to the power of 4. Right? So if you dilate a lacrimal drainage system twice from what it is, then you are reducing the resistance to flow by 4 times. So the flow enhances. So the first step is to do a balloon dilatation and see how it responds to that one. The second step of management for functional epiphora is to use intubations. And then you don't use regular silicone intubations. You use large diameter intubations, which are around 1.3 millimeters in diameter. Okay. They are manufactured by a company called Beaver Tech. So those are large diameter stents. The regular diameter stents that we see are 693 microns in diameter. So we want something which is twice the size because you want to dilate it. Okay. So that's the second step. And then you retain the stents for a period of 4 to 6 weeks and then remove it and then see how it's working. That's the second step. Then the third step, if that doesn't work, is a role of an endoscopic DCR, not external, because we might again complicate the functional component there for somebody who's already compromised. So endoscopic DCR, approximately, I would say 30% of patients tend to do some degree of improvement with endoscopic DCR for a simple reason that you have converted a 3-compartment structure, ocular surface, lacrimal system, and nasal cavity into a 2-compartment structure. So the resistance has gone down, and with every breath that you take, the negative pressure in the nose tends to drive fluid from the ocular surface. So by these 2 mechanisms, it helps functional epiphora in that process. What I am now currently working on is to use something called as chromium cobalt alloys that they deliver into coronary arteries. I'm using, I've done animal experiments and I've done in cadavers. I've got, with a lot of difficulty, I've got permission for 5 patients. For humans, because nobody else has ever used that device or equipment into the nasolacrimal duct. And here you're thinking of putting something permanently into the nasolacrimal duct. So, those are a lot of challenges in that one. So at present, that is where I'm looking at it. So that will be the 5th step if that happens. So maybe in a year, 2 year, I might be able to tell you what is the outcome of that.
Dr. Javed, you talked about Centurion syndrome.
Yeah.
How to treat that condition?
See, Centurion syndrome, fortunately in Indians is a little less because we are not by default very broad, very tall nose, Centurions like Centurions or Europeans. So, but in those patients who have, that's predominantly because the nasal bridge is very tall with them. So when the nasal bridge is very tall, the medial canthal tendon, the anterior limb, tends to get inserted much more anteriorly. And that causes a lift of the medial part of the eyelids. So in that situation, a very simple thing is that you can palpate, you'll be able to palpate your tendon here, right? A small 4 or 5 millimeter incision only in that area, and disinserting the tendon from both the sides with a very 5 millimeter kind of an incision. You can just disinsert. So what happens? The lids tend to fall back. So that's one thing. And at the same time, because the punctum has been away, because by the time you see these kids, they'll usually be 14, 15 years at least. So the punctum has been for a long time a little away from the lacus lacrimalis. So there's a secondary punctal stenosis that happens. So that combined with a good punctal dilatation and a monoca, again, prefer, it's an offbeat track, but since I'm coming to that point, we have now convincingly shown that routine punctoplasty should not be done for punctal stenosis. Punctoplasty is very detrimental to those tissues. So what has been started 153 years, now we have put in the literature very convincingly that at least for the routine cases, punctoplasty should be banned, should not be preferred choice. Okay, so anyway, that's a separate discussion. But what I mean to say is that do a simple punctal dilatation for if there's secondary punctal stenosis, and then place monoca stents if it is associated punctal stenosis. So with this, they usually tend to do very well.
Dr. Javed,
yes, sir.
Very nicely explained. We come across very often NLD blocks in infants. I mean, so how do you, what is the management protocol for them?
So at this point of time, Krigler's lacrimal sac compression that we normally advocate, we were advocating it for 1 year till 2 or 3 years back. But now I usually wait on lacrimal sac compressions for 18 months because I have seen that up to 18 months, there is usually a spontaneous resolution that happens. But beyond 18 months, I have not found in longitudinal lateral studies. So we have changed our practice patterns from 1 year to 18 months now. And at 18 months, the first step is to take those children up for probing and to see. And if there's a congenital obstruction, then we recanalize it up. And if you do that well with simple endoscopy guidance, then you would never need to repeat probing, because in first probing you'll get to know whether it's a simple obstruction or a complex obstruction. If there's a complex obstruction, you will be able to diagnose at that particular point of time, and you'll be able to take a call whether this child needs to go for DCR or something else needs to be done for whatever complexity that is. So that can be managed at the same time. So that's how we go at this point of time.
So 18 months is the cutoff time. I mean, you can wait till 18 months.
18 months, yes. At this point of time, conservatively, we can wait till 18 months. The only exceptions are if somebody has palpable lacrimal sac. You can palpate the lacrimal sac, or if somebody develops acute dacryocystitis, or somebody has already undergone probing somewhere else. So these are the cases where you can take it a little early. But for routine run-of-the-mill cases, 18 months.
Another question which generally comes up is for the intraocular surgery, whether syringing sac irrigation should be done for all cases of intraocular surgery, or just the Roplast test is good enough for that?
Not really, because Roplast usually does not show up unless there is a lacrimal sac dilatation. And lacrimal sac dilatation usually happens in a chronic condition. So for those people who are early on nasolacrimal duct obstructions, they will not show Roplast unless 2-3 years have passed by. So it's always a good idea to irrigate the lacrimal system and see. It won't take a minute for us to know, so that we save our colleagues who do cataracts and intraocular procedures.
How long do you wait for if a patient turns up with acute dacryocystitis? How long do you wait for surgery? Suppose a patient doesn't succumb to antibiotics, doesn't respond, then how do you go for?
So the practice for me now is that it doesn't matter if somebody is in acute dacryocystitis or lacrimal abscess. It depends on when my OR is at that point of time. If it is, say, like today is Tuesday is my OPD and tomorrow is my OR Wednesday. If I see an acute DAC today, I'll operate tomorrow. Even if it's lacrimal abscess, I'll operate tomorrow. Because what happens is that one, endoscopically, you can easily do it without touching anything outside. The second thing is that here, if you do a DCR, you're treating the cause also simultaneously. So in a week's time that somebody takes medication and comes back to normal, by that 1 week, the patient has already recovered from a DCR also, right? And the ability of a lacrimal abscess, even I'm just taking extreme examples of abscess, which has even caused orbital cellulitis, they respond within 24 hours completely. In the 48 hours, you would see that everything has disappeared actually. If you do endoscopic DCR. So if you have those systems and those things, efforts, go ahead and take them up straight away for endoscopic DCR. But in case if you don't, then you give them nicely antibiotics, wait for all the erythema, inflammation to settle down, because if the inflammation doesn't settle down, the external DCR becomes very messy and the tissues become very friable, suturing becomes difficult and all this thing. So have time, take your time. Once acute infection gets controlled, you can do that one. The other rare situation is if somebody, if we cannot do an endo DCR and there's a patient who's coming with recurrent abscess, not responding to medications. That's another situation and scenario which we are increasingly facing in terms of this pan drug resistance that we are having. Those kind of cases, rather than taking an incision and drainage, it's a good idea to take a 10 cc syringe with a big bore that comes with a big bore and go on the dependent position and then aspirate the abscess. So in that way, it's a very minimally invasive thing. You immediately decompress the abscess and then start whatever medications you want to give. A lot of patients that I'm seeing with resistance are nowadays resistant to most penicillin classes, including cephalosporins. So those kind of cases, I'm seeing that they tend to respond more better to quinolones. So you can change up and have a look, and at the same time keep preparing for a DCR.
With such a painful condition, will you allow you to irrigate or aspirate?
Aspirate? Oh, it's very easy. Aspiration is not painful because you go from the most dependent portion. In fact, IND is very painful because you're taking a large incision. Here it's something like a needle. It's like somebody's given an injection, so it can pain that point of time. And the very interesting point is that as you're aspirating, the pain rapidly starts decreasing. The pain predominantly happens because of the stretch of the tissues. So as soon as the stretch goes down, even during aspiration, the patient feels pain relief. Apprehension might be a different aspect, but pain relief happens immediately. Within 10 minutes, the patient will be relieved of all pain of acute dacryocystitis.
In congenital NLD, how early we can go for a DCR?
Congenital obstructions. So her question is, in congenital obstruction, how early can we go for a
DCR?
Yeah, endoscope. I usually take an endoscopic route. So how early, if you're asking, how early, the earliest I have done an endoscopic DCR in a child is 4-hour-old baby, 4 hours, age of the baby. That means on the day of birth. Okay, so that's an exceptional rare situation where that child had huge ophthalmos, and Dr. Mandal was very keen to immediately take that child up, and the child had bilateral non-development of nasolacrimal duct. So that's the extreme spectrum of it, where you can do it on day 1 of birth also. But if given a choice, I would usually wait for 4 to 5 years, if the child is giving me time, just to make our life easy and comfortable. That's it. It's just about comfort.
Sir, when there is a regurgitation through the upper punctum, as a first year, it's quite difficult to conclude whether the obstruction is at the lacrimal sac or at the proximal, at the common canaliculus. So how do we conclude with that, and then what's the further?
So you should look at the speed in which things regurgitate back, right? So if you just, as you're irrigating, this immediate regurg that happens, then obviously it is coming, there's obstruction, before common canaliculus, right? I'm talking about the opposite punctum. If it is even more proximal, it will come from the same punctum. So if it's coming from the opposite punctum and it's immediate, then it's at the common canalicular level. But if it takes time, and a good idea that once you start doing irrigation is to always watch the area of lacrimal sac. You would always see a nice stretch that happens if you're injecting. So that gives you an idea of where the fluid has gone. And obviously, it will take some time to come back. It will never be very immediate.
Sir, I have a question. I wanted to ask, in a child, when we do probing, the maximum how many settings we can do probing?
It is criminal to do in more than one setting. Right? Everything that you need to know can be known in the first setting itself. All kinds of complexity that is needed. Right? Whether the probing is going to work, not work, is there atonic sac, is there gross stenosis of the nasolacrimal duct and not an obstruction, or is there something called as a buried probe where the nasolacrimal duct develops very well, but it doesn't open in the nasal cavity. It goes into the floor of the nose. So you get to know what complexities are there and you address that complexity right there. Or you would also know that this particular patient I've taken up for probing, but beyond the bony nasolacrimal duct, everything has not developed. So I know right straightforward, there's no point in doing probing here. This guy is going to go for a DCR. So that is what you should do. See, if it is a very simple thing, if it is my child, what will I want? As simple as that. If you literally feel that it is my child, for me, they are all my children. Oh, I can cry if I have to take somebody for a second time. It is that sense. So it's all about being sensitive. And if you are sensitive, you'll start learning things. It's not a big deal, right? To learn, if you can do some complex microsurgeries like cataracts and retina, well, this is so gross. You can easily learn this.
Thank you.
So, me
But,
again, sir.
yeah, please.
Sir, how do we know at the time of irrigation that we have injured the canalicular wall? Is there a way to find, like in the OPD when we're doing it and it's a rashar, it's like it's very difficult to know if
One
we've
thing is
injured.
stop using needles. That's very important. At least we were taught to use needles when we were 10, 12 years back. That's the worst thing that can be done. Never use needles into a canaliculi. You always use cannulas. Okay, so that by that maneuver itself, you have reduced a lot of possibility of injury. The second thing is that if you have not crossed the common canaliculus and then you see bleed, that means there is a trauma that has happened to the canaliculi. If you are irrigating and the patient shouts suddenly, the patient was okay when you were putting the cannula, but once you start irrigation, patient is shouting. It just means it's a false passage. That means you have penetrated the canaliculi somewhere or traumatized that one. So those are the indications where you just take it, don't touch the patient, just give them a little bit of topical steroids and don't irrigate or don't evaluate the lacrimal system for at least 1 week till everything settles down a little. सोचने की बात है ना, हमारे मुंह में कोई जाके अगर कोई स्क्रैच करेगा तो हमको कैसे लगेगा? So we should have that kind of a sensitivity when we are doing that. I'm not going to touch here and there. And then once that sensitivity comes, you'll be surprised that how nicely your skills tend to develop. It's all being about sensitive.
Thank you, sir.
My pleasure. उत्कर्ष जी, आप बहुत दुखी दुखी लग रहे हो, क्या बात है?
It was very interactive lecture, sir. I learned many things, and during what we have learned till now, we completely opened my mind. While irrigation also, we never thought in books what was mentioned earlier. We followed that passage only. Now you told that we should first stretch and then to prevent injury and needles and probes, this difference also making a huge difference, and how sensitive the structures are. That's the basic learning is still so important. That now I realize that.
And there's a world, I can tell you that. And I'm seriously thinking about, because just to show you how and from where to where the science has gone, right? So if you have seen Cornea's that book Crashmer jo padhte hain, have you seen that book, right?
Yes, sir.
Lacrimal Drainage Atlas is like 2 volumes like that. So you can imagine the amount of literature that has come on into the last 2 years and last 10 years, right? So this, the amount that is there in today's in this science is so much that I am not able to manage lacrimal drainage system alone. I feel that now I have to get into towards either punctum or canalicus and spend my entire life there, because it's that kind of a universe over there, right? So there's a lot of scope. I mean to tell you, in whichever area in ophthalmology you choose, there's a lot to be world leaders in that area, and it's you people who are going to be, and every one of you have that capability to be the best in the world. Never think from India's perspective of topping in India and all those things. Always look at the global level, and you'll be surprised that the kind of, Dr. Ajit Babu knows. He has seen me through from his fellowship days, from my fellowship days, right? Just ordinary from any RIO, studying and coming out. But every one of you have that ability to be a global leader. And I'm global leader, I mean number one, in whichever area you choose. That's the potential India has. Right? And it's just that we need to believe in that system, that we can put up literature and we can guide the West how to manage things. And if that message is something that I have driven and inspired you, I think that work is done.
Absolutely right.
One thing, Dr. Javed, I'm seeing a lot of doctors study, especially the left eye. Is there anything difference between left eye and right eye?
Not yeah, sometimes even I used to feel, if in one OPD, if I see 5 or 6 back to back right, then you have some is it right sided or something like that. But when you evaluate a large system, so we did an epidemiological study of more than 25,000 lacrimal obstruction patients, and in that 25,000, then we didn't find any difference between left and right. It was like 49 and 51, which is not very significant. But obviously age has a role in that one. But again, what surprises me is that when I practice and go and practice in the West in many countries as a part of my professorships, I rarely come across women in those countries who have obstructions in the premenopausal areas age. Almost all of them are postmenopausal. Very strangely, in this country, I see people as young as 16, 17, 20-year-old females having that. So that always intrigues me. Why is it so much of a difference? So I was in Germany as a part of my Humboldt fellowship, and I was very keen to explore the hormonal status, and you see how things happen sometimes. So as when you're a Humboldt scientist, you have freedom. That's the highest grade scientist in Europe. So you have freedom to get into any lab in Europe, more so in Germany, and to use any of their facilities to do any of the things. So it's unlimited kind of a thing. So anyway, so when I'd been to one of the systems who were working on some other hormonal work, and I just looked at the fridge, and the fridge had almost all possible hormonal antibodies that are there. And I said, come, let's do whatever is available. And then I was doing that part. It's very, very elaborate study on hormonal, not hormonal status in the blood. I was looking at hormonal microenvironments within the lacrimal drainage system. And it just so happened that one day when I opened, somewhere on the side of the fridge, there was this prolactin hormone that was present. Prolactin, what is prolactin has to do with milk and other things. But then that thought did not come to me. I said, wow, prolactin hai. Chalo prolactin bhi use karke dekhte hain kya hai. And prolactin came out to be the most significant aspect of that hormonal things. So what I have found was that in more so in Western populations is that, see, my thought process to go with was that if I am seeing a woman's lacrimal drainage system, obviously her prolactin should be more than my prolactin if I am of the same age. That was my thought process, but that was wrong. So what I found was that beyond 45, 50 years, the men have good expression of prolactin. Women don't have great expression of prolactin. And those people who had obstructed pandos, in whose samples we studied, they had absolute no expression of prolactin. And then when we looked back into a lot of things about prolactin, we found that prolactin has a very unique anti-inflammatory action that it does. and it tends to protect prostatitis from happening in men. So that particular thing led us to prolactin, and which we are still now trying to develop animal models where we can knock out the prolactin gene and study their nasolacrimal duct. So just giving one unique examples of how things go from what point to what point. It's a very fascinating science.
Any questions for the postgraduate students? Or you want to add anything?
Or if you have some bright ideas, tell me.
Yeah.
Because the brightest ideas come from you guys. And that is one of the reasons why I don't like my fellows or my students calling me sir. I want them to call me by my first name. At the time you call somebody by a first name, that barrier is already broken, right? And you should be able to tell me whether I'm doing right. And all my fellows have that right to tell me if they ask me a question, and if I answer them that does not satisfy their curiosity, or to the extent that is there, they're supposed to tell me on my face that your explanation was totally wrong or shit, and I'm not interested in this one, or I am not agreeing with this one because this is my alternative explanation, or this is why it is there. So if you surround yourself with these kind of people, then you're bound to grow, because people are there. Your students have the right to criticize you for anything that you come up with. So again, I'm telling all these things because you guys are postgraduates. You guys are the future of this country. And I can tell you, we can rule this country. I can tell you one thing for sure. The West is in medieval times as far as dacryology is concerned. You go and look out, search for it, and you'll get to know the evidence. They are in medieval times. We have left them so far behind, right? And that is possible in every single area. This country has that potential.
Dr. Javed, the straight cannula that you said are all disposable ones?
No. See, again, what we also have to realize is that we have to always look into the economics of how we do things also. Like straight cannulas, if you make it disposable, then it's going to cost us a lot, especially if you have lacrimal practice. So what I usually do is that I have those straight Indo-German cannulas, that the ones that I showed you. I have no financial interest in Indo-German. So I think its catalog number is 2013, if I am remembering correctly. So that 25 gauge is what I use for OPD, and 23 gauge is what is used for. You can also have spine cannulas, which you can use for as a disposable mean if you want. But I usually use again clean it up, just like how we do tonometers, and then use that. So I usually prefer to avoid a lot of disposable, especially if your practice is high. If your practice is like, if you see 2 or 3 cases in a day, then it's okay. You can afford to have disposable. Nothing wrong with that. Babuji is very silent. No, he pushed me. He pushed me to do this one, and I'm thankful.
Sir, you are muted, sir.
No, he's not talking. He's just smiling.
I'm not talking. He said only he will speak for 15 minutes. I told him,
the mentor of EIZOC.
to discuss, you don't speak.
Yeah. And I found that to be very useful. Thank you. Because, in the West, whenever we go, we don't get more than 10 minutes. So it's a good idea. Anything else? You guys want anything else other than, need not be dacryology? Anything else?
Good evening, sir.
Yes.
Soumya.
Yeah, please come.
Sir, I have one doubt. I have read one of your paper on ICIL.
Okay.
So the management protocol you have told ki you have tried with antibiotics and steroid, but after that also, after steroid is discontinued, the disease progresses, and you have tried with Monoca and steroid. So should we go for Monoca and steroid from the first, or we should give the trial?
I'm very proud of you for asking this question.
Thank you, sir.
So what she's talking about is a condition, a new disease description that we described in 2018, which we call it as ICID, idiopathic canalicular inflammatory disease. Okay, so it has 5 stages of the disease, and each stage has different clinical presentation and diagnostic criteria. So what we do now, Soumya, is that any patient of ICID that we see, we first start them straight on topical cyclosporin because we want to downstage the disease. So if somebody comes in stage 4 ICID, then we want to downstage it at least till stage 1. So once we downstage the disease to stage 1, and that's the time when we intervene with a Monoca. So steroids is something that I don't use as first line anymore. So there's a sequel paper to that one, the paper that you're talking about.
Yes, sir, I have not read that one.
The sequential paper. So if you the first paper where we talked about ICID, we have shown 100% failure, right? So I don't know whether you noticed that or not. That paper.
Yes, sir, I have noticed that.
Good. So because what does it mean? It means that never be shy, even if you have 100% failure, to stand on the rooftop and shout from the rooftop that in my hands, with every possible thing in the lacrimal armamentarium, my success rate is 0 in this disease, right? Because that, if you accept that, then it gives ways to find it out. So today, what we do now is that we start on topical cyclosporin, continue for at least a period of 3 months to downstage the disease. And if it comes to stage 1, then under the cover of cyclosporin, go ahead and simply dilate and place a Monoca. Don't retain the Monoca beyond 6 weeks because the biofilms again will cause inflammation. So within 6 weeks, get the Monoca out. But during the 6 weeks, the patient is under topical cyclosporin. Get the Monoca out, the punctum and the canalicular will be dilated. Continue Monoca, continue topical cyclosporin for another 3 to 6 months till you don't find any kind of inflammation. And then stop cyclosporin and then again reassess for 3 to 6 months whether it's recurring or not. And then you repeat that protocol. So the second paper, if you just email me, I'll send you that one. It has all protocols in a flowchart manner of managing that. Yeah.
Thank you, sir.
My pleasure. Thank you so much for the question.
Dr. Patnaik, to give your concluding remarks.
So thanks, Dr. Javed, for this excellent understanding and the presentation and interaction also. So we'd like to have you also again in our EIZOC program. And I also thank very much Dr. Ajit Babu for mentoring us and also selecting the right people for different ORTS programs that we are conducting. That is for ophthalmic residents teaching series, we name it. And mostly this is aimed for the residents. And there's also, I think, with interaction with you all, getting a lot of insights into different subspecialties of ophthalmology. Thank you very much for sparing your valuable time and being with us. And I also thank our chief coordinator, Dr. VNR Subudhi. He is also taking a lot of interest and also sparing his valuable time in organizing this program. Thanks to our moderators of today's program, Dr. Sarmishta and Dr. Gyan Bhaskar, for their interaction, and also the residents present today and participated in this program. Thanks a lot, Dr. Javed. We are all obliged for this excellent presentation.
Thank you. Thank you, everyone. Now, do I have the permission to leave?
See, you spent 1 hour, 20 minutes.
Yeah.
Easily.
I never knew that it would be, there would be so much.
Yeah, you said 15 to 20 minutes, I want to finish off everything. I said, it is not much.
I'm so glad. I'm so glad.
Yeah, it's always, see, Javed, you need to interact with the young minds. It's always very pleasure.
Yes, it's indeed.
You should enjoy that, yes.
Yeah, it's very enjoyable. I agree.
No, we also enjoyed.
Enjoy with you. I enjoy with you.
Okay, good night.
You have understood the lacrimal system so well. Thank you.
Good night. Thank you so much, sir.
Thank you so much,
Good
sir.
night. Thank you so much.
Last but not least, the thanks to the entered platform to give me on the platform today. So thank you to Mr. Rahul. Are you there?
He always leaves.
I never comment from.
There.
He's there, he's there.
No, fortunately, he's there.
Rahul is there.
Thank you all. Good night. Good night.
Okay.
See you next week.
Good night.
See you next week with our RP program.
So thanks,
May I
President
request all
sir,
of you to
Dr.
join?
Pranab Ranjan sir,
Yes,
for
sir.
encouraging us.
Thank you,
Good night.
Good night.
Good night, sir.